Thank you for the faculty to invite me to present our surgical mission to Eritrea. I have to say that it's an international, multi-institutional pediatric cardiac surgery team approach, and I'm just a small part of it. And the biggest part is my former chief, and I would not stand in front of you if I wouldn't have met Dr. Urban. He's my teacher, he's my mentor, he's my surgical father, and without him I would have never become a pediatric cardiac surgeon. And the other side is that without him, this project would have never been possible. And he's the brain behind it, the heart behind it, and yeah, he's doing quite a lot of work to make this happen. So in 1997, some medical doctors from Ham came to him, to his office, and asked him if he thinks that it is possible to operate congenital heart defects in Eritrea. And as he is a gentleman, he said, well, my team must see the circumstances itself, but he thought, no, it's not possible. But he gave it a try. He flew down with a plane to Eritrea. It's a country beneath Ethiopia and Sudan at the Red Sea. And the main capital is Asmara. And it's a one ruling party. The area is the size of Austria and Switzerland together. There are 6 million inhabitants, and there are 9 ethnic groups. So if you arrive there at the main street in the capital, you think you are not in Africa. It's a pearl of Africa, some people say. But if you look at the reality, this is something different. They are really poor. They have to walk long distances to get some drinking water, and there's no real water supply. And when he arrived there and was in the hospital and saw the cat running across the OR, he said, no, it's not possible. But the team of those medical doctors, especially Peter Schwitter, convinced him to really give it a try, and then he decided to make it happen. So, but why Eritrea? It's one of the 3 poorest countries of the world. They suffered from 30 years of war. There are no human and economic resources, and until 2004, there was no medical school. This means that all the medical doctors there were trained in Ethiopia, and there was no training anymore. But since 2004, there's a medical school, but there's no pediatric surgery, and there's no pediatric cardiac surgery, of course. So if you look at the socio-economic indicators, you see that more than half of the population live underneath the poverty line, and a lot of them don't have, as I said, drinking water, and the government is spending not enough money for the health system, of course, because they don't have that much money, because the GDP is low. And if you look at how many physicians has to cover 100,000 inhabitants, there are 5 of them. In Germany, you have 418. There are just 2 midwives for 200,000 inhabitants. In Germany, there are 10. And the nurses, you can see there's also not the adequate size. So there is a high fertility rate. They are having 3 times more children than we have. So there's a really high birth rate, and the population is growing. Yeah. And it's quite a young population. The median age is 18. But there are problems with maternal and child health, because a lot of women die during giving birth. There's a high neonatal mortality, and of course there's infant and child mortality. So the incidence of congenital heart defects in Eritrea is quite high because the birth rate is that high. So if you make the calculations, we calculated around 1,400 children or newborns were born with a congenital heart defect. So if you look at the resources, There are just 5 pediatricians for the whole country. There are just 7 surgeons for the whole country. So the pediatric population is not really covered well. There are just 16 hospitals for 6 million inhabitants, and there's no infrastructure. So the objective was to create a pediatric medical infrastructure, to build and equip an operation center for children in Asmara, and to initiate heart surgery for Eritrean children on an international multi-institutional basis. Indeed, he did it very good. He received, or we received, Italian building. It was not, of course, a hospital, but with the help of an architect and a friend of Dr. Urban, the recreation and rebuilding was done. You can see there was not a good condition, but we make it happen that we have a German standard. We put, I don't know how many kilometers of cable, and every plug has 2 cables, as in Germany. A lot of equipment was brought down under, and a lot of containers with a lot of stuff, with instruments. There was teaching, of course, of the OR nurses. There is a sterilization room. And also, of course, we brought 2 or 3 heart-lungs machines there. And I think we are right now bringing a new one because of the battery problem. So we'll have, in a short time, another one there. And in 2002, in April, the first operation was done by Professor Asfour, but the ceremony and really opening of the International Operation Center for Children in Asmara was in November 2002, and this is also the first time I was there and visited Eritrea, Asmara. So you can see Professor Singer. He was a former chief of pediatric cardiology in Erlangen, and he's doing a lot of screening there, and he's getting a lot of referrals. He's teaching and training, but there are a lot of other pediatric cardiologists who have been with us since 2002. And Reinhard, I've seen you. You will fly to Eritrea in March, and before our team will arrive to screen some children and to decide whether they should be operated or not. There was one mission, and we were a little bit out of patience, and we thought, how can this be possible? We calculated that we would have so many children with congenital heart defect, but the problem is we don't get them because there was no referral. So we decided to establish a teaching of health person or health workers in the health centers. And so they are referred, or they are brought to Asmara, they receive the teaching, and you know that they get a stethoscope and to hear the murmur and decide whether they should transfer the child for further investigation to Asmara, to Zerageda. And now the system is, of course, established, but in the beginning it was that we shouted in the garden and said, the next patient. But now, one day before operation, the child is admitted to the pediatric department, receive a peripheral IV line, and is brought to the induction room where the anesthetist is doing the induction, and then afterwards is going to the OR. This is our OR. And you can see that really we try to train people that they will perhaps be doing this alone, but of course it's not easy, and I think after 10 years I can say I'm not quite sure if it will be ever possible that they're doing it on their own. But of course you have to have a perfusionist with us, and after the operation, the child is transferred to the ICU. We have 4 ICU beds on the ICU, and but we try to equip our ICU better. I will show later some pictures. Yoka is among other hospitals. So across, I think, 10 meters, there's another building, and this is the neonatal ICU. We have not, I think, 100 meters away, the maternity. So we try to make the ways shorter for the children to get to the ICU or to the neonatal or the cath lab and so on. How was the strategic approach? First there was teaching, then there was creation of the infrastructure and the setup of the International Operating Center, and then in 2002, as I said, German pediatric cardiovascular surgeons went down to Asmara and operated. But now we have also international teams from Italy and from Switzerland, and they also operate there since 2004, and I will show you the numbers later. So under the central organization of Archimed, we try to establish the infrastructure, the equipment for all cardiothoracic teams. But the funding of all teams are separately with respective NGOs. But in the end, it's a conjoined cardiothoracic team strategy because it's under the control of Dr. Urban, and it's good. And we have different participating NGOs, as I said. For Germany, it's Archimed. For Massa and Padua in Italy, it's Uncuro and Umundo. And the team in Bern in Switzerland has their NGO, it's called Kinderherzen. So the international teams, as I said, are Germany. There was Dr. Kroll visiting Asmara when he was in Duisburg from 2003 till 2008. We have Professor Stellin from Padua, we have Dr. Mosi from Massa, and Dr. Berdat from Bern. Dr. Mozi and Berdat doing mainly valve surgery, and Dr. Stellin and we are doing the whole program of congenital heart defects. Of course, they are not that complex, although we have done arterial switch operation, but we are, of course, operating the common lesions as VSD, ASDs, pulmonary stenosis, PDA, coarctation, and so on. So the equipment, as I said, it was a problem in the beginning. The X-ray machine is still a little bit a problem, but we are working on it. But we were happy to have X-rays. And the quality is getting better with every stay. And we have a new echo machine. We throw this HP away, and we have the new GE Vivid Eye. And as I heard, I haven't been in the last autumn in Asmara because there were some problems with the generator, and there were problems with the tickets of Lufthansa. But we also have transesophageal echo intraoperatively now established with another echo machine. And of course, when you start a new program, you are getting all the old stuff from other hospitals who wanted to throw the syringe pumps away. And it was really hard to work with them. They needed different syringes. The power was always getting down and so on. But now Dr. Ober funded enough money to buy new standard syringe pumps. And it's just one company, one syringe company, and of course it's easier to work with them. We of course also changed the ventilator to the new Draeger system, and we can ventilate neonatals, we can do high frequency oscillation, and so we can do every ventilator mode we want. And we have 4 of them. So, of course, you need new monitors. This was also established. You just pull it out and bring it to the ICU and plug it in again. All the data is still included, and it's much easier than compared to before because we had to change the whole system of the monitor. We teach Amaresh, the head nurse of the PICU. She was a couple of months in St. Augustine on the ICU. She learned a lot, and she's also every time helping us to get new nurses from the pediatric department and also to get them trained. They also receive, of course, ventilator training, as we have this new ventilator. And we establish the fast-track concept, so nearly 80% of our patients are extubated in the OR and brought extubated to the ICU. And this has the big positive effect that we can start early breastfeeding. And I can tell you they're bringing out the breast at the door and then going to their child. Of course, they're taking really good care of their child. They're always sleeping there. We have an intermediate care. You can see 5 beds, but often there are 2 children in 1 bed. And then after that, they go to the pediatric department. Of course, there was always problem with the oxygen. The oxygen bottle must be changed and so on. And every time I also have to change it, I thought maybe I will die during changing it. But we have a solution. We have a new oxygen system, completely independent from, and it's producing, I think, 97% oxygen. And the tank is so big that even the maternity is getting some oxygen, and the NICU is getting some oxygen. We have modern standardized cardiopulmonary bypass sets. It's the DECO Sorin. And so every team is using the same set. And it's a very small set with low priming. It's not as low as here, but we're a bit above 100 milliliters. But you need some improvisation, of course. It's Africa, still. And this is Joseph. He is a general surgeon, and he is trained by us to become also a thoracic and pediatric cardiac surgeon. He was, I don't know, 6 months in Padua? Well, 1 year.
6 months in Padua, and then he was in Germany.
Yeah, okay, good. Yeah, right. He was 6 months in Padua for pediatric cardiac, and then he was, I think, 6 months in Bremen for thoracic. So, yeah, it's true. And he's doing some cases now on his own when we are there, not when he's completely alone, because you need a complete team. We have a follow-up. We have outpatient clinic. Dr. Sigareda was trained, and she is the only pediatric cardiologist Dr. Janke or Professor Janke was talking about. So we had 1 late death, and we had 8 reoperations. And also, if our pediatric cardiologists are there, they also make a follow-up. As you can see, we have established new OR cupboards. We have a cooperation and improvement of the blood bank. And our team usually, when we are flying to Asmara, we have 1 pediatric cardiologist. As I said, he's flying a kind of 3 to 4 days in front of us. We have 2 anesthetists or 1 anesthetist. We have 2 pediatric cardiac surgeons with us. We have 3 scrub nurses or anesthetist nurses, 1 perfusionist, 3 intensivists, and 6 PICU nurses. So in a total, usually we are 18 to 20 persons. It's really a team spirit, it's a team approach. We really like to work together. It's a multi-institutional, as I said. I have been there since 2002. I spent, I think, the last couple of 10 years of my vacation, 2 weeks in spring and 2 weeks in autumn there. But I was always happy. I'm grateful that I can do humanitarian work in Africa. I've never thought that pediatric cardiac surgery would be possible in Africa. And I really enjoy getting to know people from Münster, from Bern, from Stuttgart, so from all over the country. And I think this is the best part of it. Of course, we are helping the children and so, but of course, there has to be a good teamwork. And I'm really always thankful for the good teamwork. So what about cost effectiveness? If you send a child for complex neonatal heart surgery or operation to Germany, you need 50,000 euros. And with this 50,000 euros, we are flying down with our whole team. Of course, we have our equipment already established there, and we can operate 20 children with congenital heart defects in Eritrea. So, but of course, these children are a little bit challenging. They have malnutrition, they have recurrent infection, rheumatic fever, they have, of course, pulmonary vascular disease because they are older. This child is 2 years old, yeah, and of course, it doesn't look like 2 years old. They have long-standing cyanosis, and because of the malnutrition, of course, hyperproteinemia. So to our results, since 2002, we operated 904 patients with a median age of 3.7, and we lost, unfortunately, 17 patients, but the mortality is below 2%. And I think for Africa, it's an excellent result, and the numbers are also excellent. I mean, 904 patients. So I conclude that the conjoined international multi-institutional cardiothoracic team approach is feasible, and it can serve as a model of providing a sustained humanitarian pediatric CT service in a poor, non-resourced country. These are the children we operated in one mission, and yeah, I think it was in autumn, and we are there with T-shirts, but they are always wearing too much stuff. We transport hope, and as I said, Archimede is our NGO, and the biggest, Peter, I talked about Peter. He was the guy who convinced Dr. Urban to do it. And the biggest funder is Dr. Urban. Here we'll take a picture of DHL because he was a sponsor. But we need donations, we have industrial sponsorship, we have governmental support, and of course we have charity. And thank you for attention. And